My name is Rachel Silvio, and I'm going to talk to you about respiratory acidosis for the Bio 520 urinary tube presentation. Abnormal acid-base status causes either respiratory acidosis, respiratory alkalosis, metabolic acidosis, or metabolic alkalosis. When the concentration of hydrogen changes, the ratio of bicarbonate to carbon dioxide, which is normally 20:1, also changes. The Henderson-Hasselbalch equation explains that pK is 6.1 and the log of 20 is 1.3. So a normal blood pH is 6.1 plus 1.3, which is 7.4. Now, measuring bicarbonate to carbon dioxide ratio is a better indication of acidity than just measuring hydrogen alone. Any acid-base imbalance is a change in pH because respiration has abnormal CO2, which can cause and change the amount of bicarbonate. If pH change is metabolic, then there's an abnormal bicarbonate, causing an unequal amount of bicarbonate available and the amount of hydrogen from non-carbonic acids that the bicarbonate must buffer. Acidosis is when the bicarbonate CO2 ratio is below 20:1, since a log of any number less than 20 is less than 1.3. Adding the 6.1 from pK yields a pH less than 7.4, which is acidosis. If the bicarbonate carbon dioxide ratio is greater than 20:1, then alkalosis exists. So the four acid-base imbalances are respiratory acidosis, which is a ratio of less than 20:1 because of an increase in CO2. Respiratory alkalosis, a ratio greater than 20:1 because there's a decrease in carbon dioxide. Metabolic acidosis, which is a ratio less than 20:1 because of the fall in bicarbonate. And metabolic alkalosis, which is greater than 20:1 ratio because there's a rise in bicarbonate. If it is acidosis, the pH has decreased. If it is alkalosis, the pH has increased. If it is respiratory, the carbon dioxide has been affected. If it is metabolic, the bicarbonate has been affected. There are respiratory centers in the pons and medulla of the brain that control alveolar ventilation. Chemoreceptors are specialized cells that monitor the conditions of certain chemicals in arterial blood and cerebrospinal fluid and regulate breathing during rest. Peripheral chemoreceptors are located in the carotid bodies next to the carotid sinus and in the aortic bodies next to the aortic arch. CO2 and O2 are maintained by a change in the rate and depth of breathing in order to provide for O2 uptake and CO2 removal. The respiratory center in the medulla oblongata and pons, located in the brainstem, receives input from chemoreceptors via afferent neurons in order to regulate the magnitude of ventilation and responds by sending signals to the motor neurons of the respiratory muscles, the diaphragm and intercostal muscles. Two signals that increase ventilation are decreased arterial PO2 and increased arterial PCO2. Peripheral chemoreceptors monitor arterial PO2 and respond to chemical changes in the blood, but only if the PO2 reaches below 60 mmHg in severe circumstances. Arterial PCO2 regulates the magnitude of ventilation during rest. When arterial PCO2 increases, the respiratory center is stimulated increased ventilation, eliminating CO2 from the lungs. Peripheral chemoreceptors only weakly monitor arterial PCO2. Central chemoreceptors located in the medulla are sensitive to changes in hydrogen concentration in the brain extracellular fluid, ECF. Hydrogen does not cross the blood-brain barrier, but CO2 does. In the ECF, carbon dioxide is converted to a bicarbonate ion and hydrogen by the enzyme carbonic anhydrase. The central chemoreceptors are only exposed to hydrogen from this reaction of CO2 because of the blood-brain barrier. When the chemoreceptors detect excess hydrogen in the ECF, they respond by sending a signal to the respiratory center in the brain, which increases ventilation. But what if there's a problem with ventilation? This could result in respiratory acidosis, which arises from an increase of CO2. Hypoventilation can cause hypercapnia, too much CO2 in the blood. An increase in carbon dioxide generates more hydrogen from this source, decreasing the pH of the blood. There's chronic and acute respiratory acidosis. Chronic respiratory acidosis occurs over a long period of time. The kidney increase bicarbonate to restore the acid-base balance. The acute respiratory acidosis occurs very quickly, so the kidneys can't restore the acid-base balance quick enough. This can often occur in patients with chronic respiratory acidosis because of an acute illness like pneumonia that makes breathing more difficult. Symptoms of respiratory acidosis include confusion, anxiety, fatigue, shortness of breath, shaking, sweating, and flushed skin. Possible complications that may arise from having respiratory acidosis are poor organ function and respiratory failure. There are several causes of respiratory acidosis. The first one is lung disease. It could be diseases of the airways such as asthma, chronic obstructive pulmonary disease, which is COPD, sleep apnea, and airway edema. There are also diseases of the lung tissues, such as pulmonary fibrosis, which causes scarring and thickening of the lung tissue, making it more difficult to breathe. It could also be disease that affects how the chest moves, such as scoliosis or obesity. The second one is depression of the respiratory system. The second one is depression of the respiratory center because of drugs or disease. The drugs that would have an effect would be ones that suppress breathing or slow bodily functions down, such as narcotic, benzodiazepine, type of downer, often in combination with alcohol. The third one is nerve or muscle disorders that signal the lungs to inflate or deflate, reducing respiratory muscle ability. Uncompensated respiratory acidosis is when the CO2 is high, but bicarbonate is normal, so the ratio is 20:2 and pH is lowered. Compensatory measures act to restore pH to normal. The chemical buffers immediately take up additional hydrogen. Because impaired respiration often causes this condition, increased ventilation in order to compensate can be very difficult. The kidneys are most important in compensating for respiratory acidosis to help normalize the pH of the blood. The kidneys will act in conserving and reabsorbing more bases in the form of filtered bicarbonate and new bicarbonate to the plasma. And then they secrete and excrete more hydrogen and ammonium. Emergency personnel make second-to-second decisions that could save a patient's life. When a chronic obstructive pulmonary disease (COPD) patient experiences acute respiratory failure, it leads to respiratory acidosis. The medical team must decide how to assist them quickly with non-invasive ventilation (NIV) or endotracheal intubation (ETI). NIV is the use of breathing support administered through a machine externally, such as a face mask, nasal mask, or a helmet. One example of NIV treatment is a continuous positive airway pressure, or CPAP machine, which provides a positive pressure of air through the mask and into the airway, which allows the trachea to open. ETI is a procedure in which a tube is placed into the trachea through the nose or mouth. NIV treatment can show quick results, but according to the research, most guidelines recommend avoiding NIV if the patient is unconscious because of the risk of aspiration, and some research suggests that NIV will not work if the pH is less than 7.25. These guidelines lead many healthcare providers to choose ETI, which can often lead to complications. There was a study done this year that analyzed the benefits and risks of using different treatments for respiratory acidosis on patients with chronic obstructive pulmonary disease, COPD. The study was called Pre-Hospital Reversal of Profound Respiratory Acidosis and Hypercapnic Coma by Non-Invasive Ventilation. The hypothesis is if non-invasive ventilation is used instead of endotracheal intubation on patients with respiratory acidosis, then there will be increased pH and decreased intensive care unit admissions, complications, and mortality. The independent variable is the type of treatment. The dependent variables are the reaction to treatment, including blood pH, level of consciousness, intensive care unit ICU admissions, complications, and mortality. The control group were the patients given endotracheal intubation, ETI. The experimental groups were the patients given non-invasive ventilation, NIV. While the sample size was small in this study, the results revealed that in cases where medical guidelines would have led medical professionals to perform ETI, the use of NIV helped the patient and allowed them to avoid potential complications with the high-risk ETI procedure. After performing NIV on patients, blood pH level increased and pCO2 decreased. One 70-year-old COPD patient was unconscious when emergency personnel arrived on the scene. He had a legal order not to resuscitate or to be intubated, so the medical team could not perform ETI. He had severe respiratory acidosis with his pH at 7.07, and his pCO2 was greater than 17 kPa. He received NIV for 30 minutes, and his pH level climbed to 7.24, and his pCO2 level dropped to 12.2 kPa. While the patient was admitted to the ICU for 2 days, the medical team was able to successfully treat his respiratory acidosis without the need for intubation. Another COPD patient, who was a 71-year-old woman, also experienced respiratory acidosis. When found by emergency personnel, her pH was 7.17 and pCO2 was 15.6 kPa. The medical team used bi-level positive airway pressure ventilation mode, a type of NIV, for 60 minutes while traveling to the hospital. Her blood pH showed remarkable improvement, up to 7.31, with her pCO2 level dropping to 10 kPa. These are only two of many cases that have successfully treated respiratory acidosis in minutes without the use of ETI and all the complications associated with it.